Good afternoon, my dear students. The topic for today's discussion is cirrhosis of liver. Coming to the definition of cirrhosis, cirrhosis is a diffuse end-stage liver disease process characterized by complete effacement of liver architecture with structurally abnormal regenerating and degenerating parenchymal nodules separated by bands of fibrosis. Then the etiology of cirrhosis, the causes of cirrhosis. Alcohol and alcoholic liver disease are the most common cause for cirrhosis. Next is viral hepatitis, non-alcoholic steatohepatitis, hemochromatosis, autoimmune liver diseases, intrahepatic and extrahepatic biliary obstruction, metabolic disorders like Wilson's disease and alpha-1 antitrypsin deficiency, cryptogenic or idiopathic cirrhosis, drugs and toxins, Indian childhood cirrhosis. Coming to the incidence of various etiological factors causing cirrhosis. Alcoholic liver disease constitutes about 60 to 70% cases of cirrhosis. Viral hepatitis constitutes around 10% of all cirrhotic cases. Biliary disease is responsible for 5 to 10% of cases of cirrhosis. Primary hemochromatosis for 5%. Cryptogenic cirrhosis is seen in 10 to 15% of cases, and Wilson's disease and alpha-1 antitrypsin deficiency are rare causes for cirrhosis. Coming to the pathogenesis of fibrosis, as we have already discussed, the chronic inflammation, the inflammatory cytokines like tumor necrosis factor alpha, transformation growth factor beta, interleukin 1, and other chemical mediators produced by the Kupffer cells, injured endothelial cells, dying hepatocytes, bile duct epithelial cells, and the disrupted extracellular matrix, and directly by the toxins will stimulate the stellate cells of liver present in the space of Dishy. These stimulated stellate cells will be transformed to myofibroblastic cells. These myofibroblastic cells are stimulated to proliferate and produce collagen of type 1 and type 3. Therefore, the early changes of fibrosis are seen in the space of Dishy, especially in the centriacinar part of the hepatic globule around the central vein. Classification of cirrhosis. There are various classifications for cirrhosis. The etiological classification, which is based on the etiological factors causing cirrhosis of liver, like biliary cirrhosis, cryptogenic cirrhosis, Indian childhood cirrhosis, and so on. Based on the morphology, cirrhosis is classified as micronodular cirrhosis, macronodular cirrhosis, or mixed micro and macronodular cirrhosis. Micronodular cirrhosis when the nodules of the parenchyma are less than 3 millimeters in diameter, and macronodular cirrhosis when the size of the parenchymal nodules are more than 3 millimeters. The classification is arbitrary, and there is a lot of overlap in the etiological factors causing different morphological types of cirrhosis. Let us now see the various types of gross specimens in different types of morphological types of cirrhosis. Coming to this is micronodular cirrhosis, where you can see the nodules are very tiny nodules separated by stretches of fibrosis. This is the nodule, and these are the fibrotic bands. Coming to the next slide, here you can see the macronodular cirrhosis of the liver. The liver is studded with the larger nodules compared to the previous image. You can see the nodules are large with these are the areas of fibrosis. Okay, these are the nodules, and in between you have the fibrotic bands. Coming to the mixed nodular cirrhosis, you can see nodules of variable sizes. This is a larger nodule, these are larger nodules, and in this area you can see all smaller nodules. This is relatively a large nodule separated by thick fibrous bands. This is the microscopy of the cirrhosis of liver. This slide is stained with a special stain which stains the collagen, like Masson's trichrome, which selectively stains the collagen bundles in the fibrotic septae. You can see these blue septae are all fibrotic bands, right? And these are parenchymal nodules of variable sizes, right? Coming to the clinical features of cirrhosis, in the early stages when the liver function is well compensated by hyperplastic parenchymal nodules, the patient is asymptomatic or sometimes they may present with non-specific symptoms like easy fatigability, loss of weight, loss of appetite, and so on. In the late stages, the signs and symptoms of cirrhosis of liver are due to hepatic failure, portal hypertension, or it could be because of hepatocellular carcinoma. And apart from this, the patient may have signs and symptoms suggestive of the etiological cause like alcoholic liver disease or viral hepatitis. You may give the history, or you will have different findings in the liver function tests. Coming to liver failure, one of the presentation of cirrhosis of the liver in the end stage. Hepatic failure is most commonly because of it is one of the most severe clinical consequences of the chronic liver diseases. About 80 to 90% of hepatic function is lost before the patient presents with hepatic failure. Mortality rate is very high unless treated with liver transplantation. Hepatic failure could be acute hepatic failure as seen in fulminant hepatitis. In few of the viral infections, the liver will develop fulminant hepatitis and cause acute renal failure, hepatic failure, where there is massive necrosis of the hepatocytes causing acute failure. Chronic hepatic failure is the end stage of all the chronic liver diseases. Acute on chronic hepatic failure is seen in patients who are well compensated otherwise or in early stages of cirrhosis. Only in stressful conditions like in systemic infections, patients present with hepatic failure. Sometimes patients present with hepatic dysfunction without hepatic necrosis, as in Reese syndrome. Hepatic failure, the clinical features. The patient invariably presents with jaundice, fetor hepaticus because of formation of mercaptans, due to they present with palmar erythema and spider angioma due to defective estrogen metabolism, present with hypogonadism and gynecomastia in male due to hyperestrogenemia, and hypoalbuminemia is responsible for edema and ascites. Patient may also have coagulation defects because the liver is the site where many of the coagulation factors are synthesized. They are at increased risk for pulmonary complications and present with hepatopulmonary syndrome. They also have hepatic encephalopathy due to hyperammonemia due to disruption of the metabolic activity of the liver, where liver is one of the organs where liver is the organ which removes the ammonia from the body, and when there is disruption of liver function, the ammonia will accumulate in the body and causes CNS changes in the form of confusion, stupor, coma, and sometimes death. They also present with hepatorenal failure. Hepatorenal failure is the patient with the hepatic failure also presents with the renal failure without any defect in the kidney, may be due to decreased perfusion of the kidney. Now coming to portal hypertension. Portal hypertension is elevation of hepatic venous pressure above 7 millimeters of Hg. The etiological classification or etiology of portal hypertension. The causes of portal hypertension can be divided into 3 categories: prehepatic, intrahepatic, and posthepatic causes. The intrahepatic causes are the most common cause for portal hypertension, and the commonest among that is cirrhosis of the liver. The prehepatic causes for portal hypertension are portal vein thrombosis or increased splenic blood flow. The most common cause of portal hypertension in the adults is cirrhosis, followed by non-cirrhotic portal fibrosis. And most common cause for portal hypertension in children is extrahepatic portal vein obstruction. The posthepatic causes for portal hypertension are right heart failure, Budd-Chiari syndrome, and vena cava obstruction. Then coming to pathogenesis of portal hypertension. Portal hypertension is produced by combination of following process. It could be because of increased intrahepatic resistance to blood flow through the liver at the level of sinusoids, which could be because of disruption of the blood flow by scarring and regenerating nodules, alteration in the sinusoidal endothelial cells causing vasoconstriction due to decreased nitric oxide or increased secretion of endothelin 1 and angiotensins. Or it could also be because of sinusoidal remodeling and anastomosis between the arterial and portal system in fibrous septae, imposing arterial pressure on the portal circulation. The second process by which portal hypertension develops is increased portal venous blood flow resulting from hyperdynamic circulation due to arteriolar vasodilatation in splanchnic circulation. The clinical consequences of portal hypertension are ascites, splenomegaly. The spleen may enlarge up to 1000 grams, and portosystemic shunts. Due to portosystemic shunts, the bypasses develops between wherever there is portal and systemic circulation share a common capillary bed. Such portosystemic shunts are seen in the rectum, which will present as hemorrhoids. They may develop at cardioesophageal junctions, where the patient will develop esophageal varices, and this rupture of these esophageal varices can sometimes cause heavy bouts of hematemesis and sometimes may lead to death. And around the falciparum ligament in the umbilical region, causing caput medusae. Encephalopathy may be due to liver failure. These are the clinical presentation of liver failure and portal hypertension: hepatic encephalopathy, malnutrition, spider angioma of the skin, esophageal varices, splenomegaly, periumbilical caput medusae, hemorrhoids, testicular atrophy, ascites, splenomegaly, esophageal varices, and caput medicine. Thank you.